we would like to shed a light on our study, which was about the outcomes of ANCA vasculitis and end-stage kidney disease patient. So ANCA stands for antineutrophilic cytoplasmic antibody-associated vasculitis. It is usually affecting small and medium-sized vessels, and hence the organ involved, especially the lung and the kidneys, are more predominant. Sometimes skin rash or neurological manifestations, but rarely the cardiac involvement. It has been classified according to the phenotype to 3 different types. Microscopic polyangiitis, granulomatous with polyangiitis, which is used to be formed as Wegener's, and eosinophilic granulomatosis with polyangiitis. And there is another classification which involves the serologic classification, whether the patient has a C ANCA or proteinase 3 ANCA positive disease versus patients who have myeloperoxidase ANCA. And you can see in patients with the granulomatous with polyangiitis, 75% of them, they will have C ANCA positive. And like microscopic polyangiitis, majority, they will have the myeloperoxidase ANCA disease. While talking about this, this is a very uncommon disease. It affects around 20 per million, and male predominant, usually at late stage of, and their 6 or 7 decades of life. And you can see this map, which depicts the ANCA vasculitis worldwide. And there is limited studies from the MENA region. And there was always this distribution in Asian and South European, they will have microscopic polyangiitis more. And with that, the pathophysiology behind it is that ANCA antibodies will attach to the neutrophils, and this will activate a cascade of complement system and leading to the clinical manifestations of this disease. And for the last 3 decades, we have a large randomized trials conducted for both knowing which best option when it comes to the induction therapy and the maintenance therapy for this group of patients. And currently approved, the induction therapy usually for the first 3 to 6 months, in which rituximab and cyclophosphamide have almost similar efficacy along with the steroid, and for maintenance therapy up to 48 months. Again, azathioprine with prednisolone versus rituximab. And the landmark trial, which was done and published in New England Journal of Medicine, was discussing about the plasma exchange role in such group, have shown there is no major difference. And even when it comes to the pulse steroid, lower dose of steroids has been equivalently good outcomes compared to high dose. And unfortunately, despite all of these efforts, still there is a 20 to 40% risk of progressing to end-stage kidney disease. And that's why we conducted our study to know the outcomes of such a group. So we have done a retrospective short review study at Tawam Hospital over the last 6 years. And we included patients who had ANCA vasculitis leading to end-stage kidney disease. And the data were extracted from electronic health records. And we used the descriptive analysis because of small sample size. Let's go to the results. So out of 1,500 patients who required renal replacement therapy at Tawam Hospital for the last 6 years, I mean here all the different indications for renal replacement therapy, we have found only 7 patients who met the inclusion criteria, in which they are dialysis patients and they also have an ANCA vasculitis. And the mean age was 51 years, and 57% were male. Then, according to the type of vasculitis, almost similar distribution, because multiple size we cannot disclose a predominance of one over the other. But the microscopic polyangiitis found in 57% of the patients, while ANCA was in around 42% of patients. In terms of comorbid conditions prior to vasculitis, a majority have hypertension followed by dyslipidemia and then diabetes. Only one patient in this cohort, she was having diabetes, and in this stage, she was started on dialysis. They thought this is diabetic nephropathy, but eventually, because of recurrent chest presentation, she was diagnosed with microscopic polyangiitis. And all the patients have acute kidney injury, severe one, stage 3, with a mean creatinine of 480 at the time of the diagnosis. And the biopsy was done of them, which showed crescentic, post-immune crescentic glomerulonephritis. In terms of the induction therapy for our cohort, all the patients received steroids, and majority received rituximab, around 85%. Patients with severe pulmonary hemorrhage or pulmonary renal involvement, they required induction with cyclophosphamide, again, with sometimes plasma exchange in 42% of cases. How about the progression to end stage? In our cohort, the median duration was around 1.7 years from the diagnosis of ANCA. And majority of patients were maintained on hemodialysis, 85%, and only one patient was maintained on peritoneal dialysis. And for hemodialysis patients, also the majority were through arteriovenous fistula. Let's go to the maintenance therapy for our cohort. Azathioprine and prednisolone was the cornerstone. 85.7% were maintained on this, and only one patient was maintained on regular rituximab every 6 months. How about the complications? Relapse of vasculitis, even though it is rare, after starting dialysis, in our cohort, we found it to be high, around 57.1%. Along with recurrence infection was also high, and 71.4%. And for the infection, majority have predominant pulmonary infection, bacteremia found in only 3 patients, and peritonitis only 1. And we have 2 patients who had COVID infection. Luckily, such cohort, they have mild disease and without major problems, and they also improved without the need of any antiviral therapy. So from the cohort of 7 patients, 2 patients underwent living kidney transplantation. That was successful. And they were maintained triple immunosuppressive medications, and there was no episode of rejection. You can see the details of that patients there. Also, we did not find any malignancy in our cohort, but 1 patient had ischemic heart disease. And in terms of mortality, there was 1 patient accounting for 14.2% who had died because of septic shock and required ICU care. So, so let's move to the discussion. If you compare our cohort with another cohorts from European countries, you found that in this study, for example, they have 11 years retrospective study, and they included 41 patients. And you can see 30% of patients have acute kidney injury. They require dialysis at the initial diagnosis, and only 50% have improved after proper induction therapy. But the mortality remained high at 1 year, which was accounted for 12%. And for the risk factors of recurrence of vasculitis in such group, younger patients, they are at high risk. Patients who have microscopic, patients who have ANCA or BR3 ANCA disease, they also have a high risk of relapse. Patients who have stopped immunosuppressive therapy early on, they are also at risk. Some also advocate for genetic studies, genetic predisposition as one of the risk factors. But for hemodialysis, patients maintained on hemodialysis, they are a very, very low risk of relapse, accounted to 0.08 per episode per year. In our cohort, you have seen it was 57%. And there is this nice renal risk score for ANCA-associated vasculitis that was developed. And it's basically looking at the biopsy finding of this patient and the kidney function with estimated eGFR with the 3 different predictors, normal glomerulus, and also the tubular atrophy, along with the other finding of estimated GFR at presentation. And they will give you low, mediate, high risk for progression to end-stage kidney disease. And this was being validated on a larger study, including 147 from South European population. And they mentioned highly specific. And I have done this score for our patients, and they were at very high risk of progression to end-stage kidney disease. With that, I would like to conclude that ANCA vasculitis is uncommon in our dialysis patients, a single center experience, but this was the only and the first study in United Arab Emirates. And for the maintenance therapy, we have used steroid and azathioprine, and 1 patient was maintained on rituximab. Again, the relapse risk, the infection risk was really high on our cohort, and this need to be treated and managed as early as possible. With that, I would like to thank you for your kind attention.